definitely like racial discrimination. It was one form of trauma that would affect certain minoritized communities specifically. And it's a balance of if someone has some paranoia about something that's related to how they appear physically, that probably buttresses that belief.
That's Dr. Regina Graham. While most mental illness goes untreated, it is especially true in minoritized communities. We explore why and give advice for anyone with a loved one with severe mental illness. Welcome to our podcast, Schizophrenia, 3 Moms in the Trenches. From the place where schizophrenia and real life collide. East Coast, West Coast, Middle America. With Miriam Feldman, Mindy Greiling, and Randy Kay. Welcome back to Schizophrenia, 3 Moms in the Trenches. It's been about a month because we've been busy with things, but we have a lot of exciting things lined up for you. I'm Randy Kay, author of Ben Behind His Voices, here with Mindy Greiling, author of Fix What You Can, and Miriam/Mimi Feldman, author of He Came In With It. We're 3 moms. We each have sons with schizophrenia, and we're kind of deep in the trenches because we've been at this a couple of decades. So whether you're new to the schizophrenia family community or you're deep into it like we are, we're just here to share information and support. So thank you. And today, whenever you're listening, this episode is about something we've mentioned, as we're very aware, 3 middle-class white women in America, but we have tried to be an ally and be very aware of the specific challenges of schizophrenia in minoritized communities. But rather than try to talk about it ourselves, we have brought on an expert, and she'll be joining us, Dr. Regina Graham, who is Medical Director of Early Psychosis Programs at UC Davis School of Medicine, will be joining us in a few minutes, and I'll tell you more about her in just a moment. So since it's been about a month, Mindy, I know a lot of listeners have asked on our Facebook group about Jim and how he's doing. I know he's just moved into housing and had a bit of a glitch.
That kind of covers it. I had Jim moved in, and unfortunately, a week after he was there, Roger and I traveled, and then we came back for a week, and then we traveled for another week. And one of those weeks, by the way, was the Treatment Advocacy Center AOT implementation symposium, and that was an incredible experience. But for Jim, it was very inopportune time for us to be gone. And, I think I mentioned on our last podcast that I felt like a weight was lifted off of my shoulders when I knew Jim was going there, and we were so relieved. And I think I went overboard thinking, now they're going to do everything. So I just want to advise our listeners, if you get to have your child go into wonderful supportive housing like Jim has, don't do that. You still have to be the mom, and you still have to be involved. And at least while you're living and healthy, I think you'll always have to do some of that coordinating. But Jim didn't eat. He got depressed. He got lonesome. He really has never lived alone. He's always lived with somebody. And the small times he's lived alone, he's had relapses. So he's not alone there, but he's all by himself in his apartment. He's used to, having people around. So he just got lonely, he got depressed, and stopped eating, and he lost 14 pounds in 2 weeks' time, despite the fact that he's on Mounjaro and other things to help him not eat too much. So the housing place had to call an ambulance and send him to the hospital. So that's what we came home to, was Jim in the hospital for about a week, and they just basically fed him. Unfortunately, they also kept him in bed like hospitals tend to do. So he got really weak, couldn't walk again, and had to go home with a walker. And so fast forward to now, things are getting coordinated. Jim has lots of people to do lots of things, but the mental health system, as we know, doesn't communicate very well. So here's my tip, and I will end with this for now and keep people posted as I go along. But my tip is, the mental health system is not coordinated. So the mama bears or papa bears have to do it. And so I have made an e-group. I've got 11 people on it, all people that are helping Jim, including Jim. And I just throw out whatever we need that's going wrong. Like today, his Lyft money ran out. He has money from the county that he can use for transportation, and all of a sudden there isn't anymore, and he's got half the month left to go. So what can we do about that? Or the place where he gets his UAs, urinalysis, and blood draws is closing. What to do about that? I mean, all these things. It's a wonderful thing that we have lots of minds and heads to do things. But without this coordination, it just wasn't working for Jim. Nothing was happening. And also he was saying, I'm fine. We know that drill. And then the people were just taking him at his word, but it wasn't working. So don't give up, stay involved. Don't be afraid to be a hovering mom for a bit longer, even when they do get into great supportive housing.
Thank you for that tip. That's, it's all about the coordination of care. And I've often found with Ben, his dream was to live alone, and it has yet to work out. So and if you're a practitioner who runs housing, be aware that just because someone's moved in doesn't mean they're emotionally moved in. And, that the transition is difficult. So, Mimi, how about you? Can I just say I saw a picture, it was on Facebook, so I guess it's public, of your son, Nick, with a drawing pen in his hand, making some art. That just made me so happy.
Yeah, it's been a good couple of weeks. One thing I want to say apropos of what Mindy was saying is that, Nick with his ACT team also has all these people, this wraparound care. But again, if I just leave it to them to communicate, and they meet every week, all of them and everything, but so many things fall through the cracks. I made also a group text with all his people on it, and we call it Team Nick, and that's where everybody communicates. And since we've done that, communication just is the big deal. And again, they'll ask, like they would ask your son, how is he? And he'll say fine, and he's not fine. And if you had heard that, you would know, because you're the mom. And that's what I go through with Nick a lot too, is the doctors or the clinicians will ask him, how's this, how's that? And he'll always give them the answer that he thinks that they want to hear. And I have to stand behind him and go, so that they know. But
great minds think alike. That is exactly what I learned. I should have talked to you first.
Yeah, well, it's very helpful. And as far as Nick, I took Nick, when we had New Year's this 2025, I decided that my commitment was that I was going to take Nick to visit his sisters, a couple times a year, each sister at least, because Nick. And this is again how Dr. Laitman says that all our kids, it's so homogeneous. Nick lives alone and he loves it and does great alone, and refuses to even consider living in any kind of group housing. And luckily we can afford it because he has his subsidized housing, but he does well on his own. But we took him on this trip, and it was the best trip yet. And we went to Nick, and I went with my youngest daughter, Rose, to a life drawing class. And we sat for 3 hours and drew a live model, all three of us. And it was terrific. It was great.
That's fantastic. And real briefly, did you tell your story to an organization in South Africa? Did I hear?
Yes, I was asked to speak at a support group in South Africa. Turns out Dr. Laitman also spoke with them a while back. And
so Dr. Laitman, if you don't know, is someone we've had on the podcast a few times, and he's a strong advocate for the proper use of Clozaril. You can check out our episodes. I'm not sure of the number right now. It might be episode 18, but just do a search on Laitman when you have our podcast, and you can hear what he talks about. Go ahead.
Yeah, so it was very interesting. I did a little research ahead of time. about the system there. And what I found after interacting with these people is that a lot of similar problems. Housing is a big issue. They don't have as many of the clozapine specific problems that we have. Um, but it was just all very interesting. And, to go to another culture and talk to other people, it was fascinating.
That's wonderful. And just to be clear, you didn't get to fly there. This was virtual.
I zoomed.
Zoom. We were so jealous until we heard it was Zoom. But anyway, but to talk to another culture is amazing. And I'm going to be very brief here. If you're new to the podcast, my son Ben has had quite a lot of ups and downs since my book came out, which was 10 years ago. Mindy and Mimi's were more recent during COVID. But at the moment, he's sobering up, and knock wood, he's been passing all his urine tests and he's been sober, but he's refused medication since like 8 months. And so talking to his voices is starting to annoy his housemates, and he's in danger of losing his housing. So that's where we are. And just to show you, again, we talk a lot about the cognitive deficits when someone has schizophrenia. I didn't hear from him for 10 days. And of course, where do we go? Is he alive? But like you, I'm pulling strings in the background. I'm like backstage pulling strings. Nobody can know. And I contacted the house manager, who said, oh yeah, I think he told me he lost his charger. And I'm like, this boy, I'm sorry, he's a man, but he's a boy with 144 IQ, can't figure out how to contact me or his conservator to get somebody to send him a charger. And so he just lives without a cell phone. It's like, oh, I'm at the bottom. I guess it's pretty good down here. So anyway, I contacted his conservator and said, please send him a charger. And she did. And then I started hearing from him again. But it's like, how are you? Fine, cool, just stuff like that. However, during all this, while I'm compartmentalizing, I got to go to an amazing conference called Changing the Narrative of Neuropsychiatric Brain Disease. And we are going to have Dr. Rocco Murata and his wife, Lisa Mann, on the podcast. And when their book comes out, called Reimagining Lives, and it's about the techniques that he's been using at Silver Hill Hospital and translated into actionable steps for other people to use. So it's very exciting. It was very exciting to be there. A lot of fans of the podcast who said that they just love us and the as much as there's a lot of podcasts with experts, they love the grassrootedness of us. So you're welcome and thank you. And just as a reminder, before we bring on Dr. Graham, is this: we love hearing from you. But I need to remind all of our wonderful listeners that we are exactly what the title says. We're three moms in the trenches. Yes, we have other skills. Yes, Mindy was a state legislator for 20 years. We've been in the trenches a while, and we're experienced, but we're not experts. So recently we've had people go, what do you think of the keto diet? What do you think of this doctor that does brain scans for $5,000? You should know about this. And what I want to say to you is this: we're not going to speak about anything we don't know about. So even if we're aware of these things, a really good thing for you to do is to join our Facebook group. We have a community there. Just search Schizophrenia Moms and you'll find us. And you can talk to each other and ask each other about your experiences with these people, because, we are what we are, and we can't just, we don't bring on people to further their businesses. We just try to bring you information as we see it and share our experiences, because you've told us you like to see it, so you don't feel alone. But you are welcome to join our community and bring up questions like that, and you can talk to each other. So we're not sponsored by anybody. This is why some of the people told us they love our podcast, because we're not sponsored by it. We make no money on this. We are just doing this as a labor of love. So there are things out there, but if we don't have personal experience with it, as we have had with Clozaril, and right now my son's on another med. We're not here to talk about any particular med. All we're doing is sharing our stories. So I thank you so much for your interest. I thank you so much for your suggestions. If it's something we're not qualified to talk about, we're not going to talk about it, which brings us to something we're not qualified to talk about, which is schizophrenia in minoritized communities. So to do that, I will read you some statistics, though, and this is the National Institute of Mental Health. Now, we know nearly 1 in 5 U.S. adults lives with a mental illness. People of color have rates of mental health disorders similar to whites, but they're more likely to last longer and result in more significant disability, because even though most mental illness across the board goes untreated, this is especially true in communities of color. 52% of whites with mental illness received mental health services in 2020, compared to 37.1% of Blacks and 35% of Hispanics. So in order to talk about this, we brought in a wonderful expert, Dr. Regina Graham, who is Medical Director of Early Psychosis Programs and a clinical professor at the UC Davis School of Medicine. She has expertise in intensive mental health settings, including inpatient, residential, emergency interventions, and especially working with vulnerable population. She has a passion for prodromal, early and first episode psychosis and its management. So please enter and sign in, please, Dr. Graham.
Thank you for that wonderful introduction.
Well, you're welcome, and welcome to the podcast. We want to just hand this over to you, to talk about what you'd like us to know, a bit about what got you interested in this, what you have noticed, and for instance, how does cultural background impact the experiences of schizophrenia for the individual and their loved ones and the care they get?
So I think the statistics that you brought up in the beginning about the delay for treatment for people in minoritized communities, that has such an effect for all illnesses, but particularly things like schizophrenia, which we know the earlier you can intervene, it really can change the trajectory of prognosis. And so even things like we have all of these early psychosis programs. I work in one of them, and they're wonderful. And also there are statistics showing that these programs are less, they're being utilized less by people in minoritized communities, such as by Blacks and Latinos. And so, the longer you wait to get treatment, the harder it is to get people back to their baseline.
Why do you think that is? Do you have any theories about?
I think just in general, the information about mental health and what it looks like is not equally distributed. I think particularly things like schizophrenia can be confusing in the beginning, because it can be the prodromal symptoms can look like things like depression, or if someone's having problems concentrating, someone might think, oh, maybe they have ADHD, and then they're misdiagnosed. So I think just knowing that you have an issue and what to attribute it to is like a problem. And then once you do know, then you have to deal with everything like stigma, getting access to care, and then having your team who's treating your family member and the individual to understand their background. And I really think of, everyone has a culture, and but for the minoritized communities, they might be coming with specific things in their culture that make it harder to access mental health, or feeling the stigma about what they might think either other family members, other people in their community, and or the mental health system might be thinking about them, that might keep them away from participating and trying to seek treatment.
I was just in New York. One of the times I was gone when my son was falling apart in his supportive housing, I was on a Rhodes Scholar trip for Broadway, and we saw 3 Broadway plays. One of them was named Purpose, and it was about a Black family, African-American family, and it was kind of loosely based on Jesse Jackson. The father had another last name, but he was, pretty much looked and sounded, and the play was written as if you had been Jesse Jackson and his family. And there were, one son was the junior to the father, and as part of the story, he had bipolar disorder. And the family just, danced around that, but particularly the father did not want to hear that about his son, that he just needed to buck up and move on and quit, not doing well in life. And it was just complete denial. And then there was this young character who came in, a young African-American woman who was a social worker, and she was trying to deal with the family and get them aware of things. But she also failed to do that. It was a very funny play. It had a lot of poignant things, and this bipolar denial was just a subplot. But to me, having Jim in our family, I just resonated so to that whole family and how they were not dealing with the son with bipolar disorder, which was very clear that he had it as you watch the play.
I think it's such a journey, right, for both the individual with the illness to hopefully accept it to some degree, and also the family members. And I like to think of it as like you have to walk side by side. Like you can't go ahead of them where they're at. And then you can't not give them information that could be helpful. So if you see the person clearly has bipolar disorder, you have to say it, even if that's upsetting. And I think that, sometimes it's helpful to learn the language that the individual and their family wants to use to describe the illness. They might know other family members who have similar things and they have words or terms they use for it, and that might feel less stigmatizing than using something like bipolar. And then I think the other part is not losing hope. So like saying, okay, someone has something like bipolar or schizophrenia, and it's treatable, and there's things that can help improve things. It's not, I'm just telling you this diagnosis to, slap on a band-aid of like stigma and saying this is hopeless. But the reason why we're diagnosing is because we want to like have the correct intervention and that there could be improvements. And a lot of people don't know that. They just hear these words and it's just like, oh, everything's going to be terrible forever.
Right. And so far, everything you're saying, I think, is applicable, whatever culture you have. Do you find in your work that there is additional stigma or you mentioned lack of education, like in the minoritized communities? Do you feel that the access to treatment, the access to a diagnosis, that is different, is more difficult than it is for your average white person?
I think on average, I think people in minoritized communities have their own way of dealing with symptoms. So that don't involve the mental health system. And so, even the idea of who gets treatment there might be very extreme. Like, you don't go to a mental health provider unless, you're homeless walking on the streets and you're unhoused and you're talking to yourself. That's someone who gets mental health treatment. Or someone who had a recent suicide attempt. In their mind, that they might think that. And so I think just education about like what it involves. I mean, and sometimes there's also misperception, particularly with people who are immigrants, that if you go to a hospital, that means that, or you go to emergency room, that means you're going to be like locked up forever. I've definitely dealt with that quite a bit with families, that wherever they came from, if someone needed mental health, that means you're like locked someplace forever. Whereas like we have the opposite problem in this country. Like people are begging for hospitalization. But just, explaining that. And I think just like education, I always talk about um, being ready to take medication, like just little things that you might think are like, um, you don't have to say, such as if you're traveling, bring medication with you and continue to take it. Some people are like, oh, well, if I go to a happy place, a different place, I don't need medicine because my problems were contained to wherever I'm living or whatever situation that is. So I think, you know, I think we can't assume. We have to ask, each family, each individual, like what their understanding is. Because some people also have other family members in their family who have mental illness, and they may have dealt with it in different ways. And so that also might be an impairment. So they might know about it, but the way they think that it's treated or dealt with could be very scary. And that's all.
My son entered the mental health system when I had to call the police because we could not get him to go to the doctor to take medication. And then he got so sick, we ended up having to call the police. And I know the history, just, not personally, but I certainly have read a lot and heard a lot about the history of the police. And I'm from Minnesota. So we had the George Floyd incident right here in Minneapolis. So I would imagine that's adds to the barrier if people have someone in their family who's that sick, but would be afraid to call the police.
Yeah, that's always like, I've dealt with that many times, that both Black parents and family members and Latinx families, for different reasons, don't want to call the police. And every state is different how you get involuntarily hospitalized, but in California, law enforcement is like a huge gateway, sadly. Calling 911 and having the police respond is a way to get to a hospital. We are trying to change it and have some mobile response teams, but by and large, a lot of times, if you're outside the hospital and you need involuntary treatment, law enforcement is involved. And it's really scary. And, I try to coach parents who will say, well, I'm afraid maybe they'll seem like they're going to be aggressive and then they're going to get shot and die. And isn't that worse than like staying inside the house and having whatever symptoms they're having? And so it takes a lot of convincing, a lot of convincing. And I would say that fear is like, regardless of socioeconomic status. I've heard parents say that very, very often.
Really? So it's the socioeconomic status has less to do with it than just the culture. Like, I mean, I teach NAMI family to family classes, and one time I was the only white person in the room, and I loved it, and I had to just say, hey, I know I know what I am, so, but we all got along great, but I found there was a cultural difference. And for me, and this is just an observation because I don't know, a lot of the families told me that they wanted to keep it inside the family as long as possible. And that, I think that's true in a lot of cultures, but that was a barrier to getting the early treatment that they wanted. And, you're in the early psychosis program, so you probably see people when they've come in, but do you have dealings with the people who have yet to kind of bite the bullet and come in for help?
Yes, yes. I mean, especially in other situations. Well, now I work outpatient, so someone voluntarily coming in, but particularly in ER or an inpatient, you have people who don't want anything to do with it. And I think, again, you just have to try to give as much information as possible. And even also, I mean, honestly, even education about things like HIPAA and mental health information. which a lot of people don't know, that like it's even more protected than your general health. You have to give an extra layer of approval to release the information. And so even letting people know that like just because you're seeking help doesn't mean it's going to be like announced on the radio or like, on Facebook Live. And just trying to like help them understand that, or people think also in terms of someone who's in school, that like everyone in school is going to know that you're seeking mental health treatment. And that's not, I mean, if you choose to disclose that, but it's not a guarantee that they're going to find out.
I would like to know about your clientele of patients. Are they all Black? When I was, or all people of color or not? When I was in high school, I'm a tall person. If you met me, I've shrunk an inch or so, but I was almost 5'9". And so whenever I saw, the basketball players with a girlfriend who was 5'2", I thought, how dare they? Those tall basketball players should be saved for tall women like me. And so, there's such a dearth of providers of color, especially psychiatrists. And so how do you manage your patient load so that you help the people who need you the most, or do you just take who comes and work just as well with other cultures?
And I guess we should add, if you're listening to this and you're not watching it on Facebook, Dr. Graham is a person of color, just in case.
Right. We didn't mention that.
I thought that was obvious, but so yeah. So go ahead.
So our program takes whoever is referred, and we have individuals from all different races and ethnicities, and I mean, I think, as just dealing with early psychosis is such a rare thing, and people are desperately seeking treatment of any culture. And in our clinic, we also see like a range, both of like private insurance and also some Medicaid. So it runs the gamut. And I'm sorry.
I said I have a question about trauma. How could trauma impact members of minoritized communities with schizophrenia? Is trauma a bigger issue there, do you think? I mean, we've already talked about the police and the relationship with the police, and it is fraught. I've been afraid to call the police myself, and I'm just another middle-class white woman. But trauma, I'm interested in that.
I think definitely like racial discrimination, is one form of trauma that would affect certain minoritized communities, specifically. And I think that, it's a balance of, if someone has some paranoia about something that's related to how they appear physically, of both acknowledging like there is a reality and some lived experience that probably buttresses that belief, and also possibly it's extreme for you, and it's you're adding to what does exist, and it's making your life even more hard and impaired. But I think I always try to like find the seed of like what is actually happening to kind of validate that part, but also not say, okay, well, everything that you're paranoid about that could be related to race, like assume that it's 100% happening exactly the way someone is describing it. And then I think it can be like very depending on the situation. Unfortunately, there's over, well, number one, I was just say the largest provider of mental health services in our country, including in California itself, is the incarceration system, prisons and jails, and minoritized communities, Black and Latinos are overrepresented in that system, and getting some degree of care there. And so, if you're associating mental health treatment with prison, that doesn't lead to like a very positive feeling about getting involved in the system.
Thank you. Bringing it back to, I'm hearing so much in common. Like, all the families go through does he have it, does our loved one have it? I'll try not to use gender, but, does our loved one have this illness? What can I do alone until people don't know? Like, we all go through this. And according to the statistics, the same percentage of people get mental illness regardless of the culture. It's the lack of treatment in the minoritized communities that gets in the way. And summing up what I think we've discussed so far, as part of it is perhaps increased stigma, lack of education, needing to know more about it, to know about it further. But some studies that I've read, and I can't recall where right now, but I've talked about the effect of city living versus rural living, and poverty versus having a lot of money. Certainly, listen, a lot of people at this conference I went to have $40,000 a month to send their kid to a farm, and that's great, but I don't, and a lot of people don't. So yes, certainly I think money has something to do with it, but money is no cure, because I know a lot of very rich people who still struggle. When your loved one has schizophrenia, it's across the board grief for everybody. But the rates of poverty, cultural influence, defining minoritized communities, it's any groups excluded from opportunities and power structures in our society. So if you were to have the power to right the wrong of people in minoritized communities getting care later and less frequently, what would you love to change about things? That's a big question, but
That's a good question.
Yeah. I think in terms of like really doing the outreach, so wherever these communities are, so at schools, I think, churches, mosques, and I think just giving information that these things exist, there's treatment. And it doesn't mean you can't do the other treatment that you might have that's outside of the medical system, depending on what it is. But also we want you to do this other mental health system treatment. I think that would make a big deal. A lot of people don't even think, they think also there's an age where someone gets a mental illness. You have to be like 25 and above or whatever. And they say, well, isn't someone too young? And so just getting that information, I think it's just,
that's huge.
I think a lot of people don't know. And if they do know, and I've also heard this a lot too, of someone who maybe their loved one has been sick for a while. And yes, maybe they were stigma. Yes, maybe they were denial. But also they're like, well, if I really knew what was going on, I would have presented this person to try to get them help sooner. But I actually I had 1,000 other reasons to explain what I thought was going on. And I didn't know.
So definitely making education and awareness available so that it's less stigmatized. Do you think schools are part of the solution as well?
I think schools, yeah. Young people, they also advocate for themselves. They'll tell their parents, like, I need help. Take me here to get help. And so
that never happened to me, just saying. I was like, I'm fine. I don't need school. I don't need a job. A job is a government plot. I don't need. So that would be like a miracle for my son to say I need help, but some do. Yes.
I've been in recent years somewhat critical of all the money that is being spent on these glossy, splashy stigma campaigns, when what in my opinion, we really need are more hospital beds and housing and education and access to doctors and all these things. But at the same time, do you think that maybe this specific area actually more of an outreach of that kind of a campaign about stigma and about the culture around it, directed specifically to Hispanic culture and those, that
Muslim
yeah,
culture,
Muslim, Black
everything that
culture.
we have here.
Maybe it's time to fine tune the stigma approach, because just this constant talk about, yeah, you can have feelings and you can talk about it. And yeah, I think we need to get more specific, because I think there's very specific areas and groups who aren't getting the message.
I think that, having a anti-stigma campaign, that someone from a minoritized community saying, like, best would be lived experience, and talking about it. I think that would go a really long way. Even something, for example, Simone Biles leaving the Olympics, and saying that, she had to take care of her mental health. That was huge.
That was huge. What
And
about them? Oh, go ahead.
and just, it was huge in many ways. Number one, some people also, well, does she have mental health issue? Like, the criticism, but then also people just saying, oh my God, thank you for saying that. And we never had anyone like you, a Black woman, say that, I have to stop because I need to take care of my mental health. So I think just even like big in her life, but I think that also had like a huge impact globally.
You mentioned Black churches, and there's research that shows that that's often the first place any person goes from any culture is their church and the pastor or the imam or whatever. Are you making any inroads yourself, or is anybody into some of the attitudes in some of the Black churches anyway that other guests that have been on our podcast have talked about, that the idea that, you would pray harder about it, or, it didn't necessarily end up with being referred to you or somebody that could help the person if they also needed medication, or more than the church could provide. So is that a place where you're educating, and are we getting any further in 2025?
That's a hard question. Me personally, I don't do outreach there, but I've definitely had a number of patients who, because of religious reasons, they or their family didn't want to take, psychiatric medication. And we did involve their religious leader in the treatment plan. So, personally, I like to say things like, God created, if you believe God created the world and all of these things, then that person is also part of creating medication. And it's not necessarily an either or thing. We want to use everything that's available to us. And personally, I found that a lot of, I guess, the religious leaders who are providers who are willing to join in the treatment team are actually pretty good of saying, like, I know, you have this belief, but it's okay to also use these kind of treatments. So I think, it is, as much as you can, bring those people in, or at least let the individual and the family know you're not anti that thing, whoever their leaders are, because then it just like leads to keeping secrets.
Yeah, you've touched on a really
about what's going on.
Yeah, that's a really important aspect. I know when I spoke at a health conference in a state where a lot of the state is rural, the city practitioners were like, yeah, let's get the pamphlets. And the rural people were like, our pastors are just going, pray harder. And so, that was, in a way, that's a minoritized community as well, no matter what color your skin is, right? So, we're trying to address a lot of issues. But we only have a few minutes left, and the story of Simone Biles was so powerful. Do you have any other specific stories about how individuals from minoritized communities with schizophrenia might hesitate in seeking treatment and what you did about it?
I mean, I like
Without
this.
mentioning names,
I know, I
obviously.
know, I know,
Yeah.
I know. I'm trying to choose one story.
Okay.
Um, I mean, I think in terms of, I just want to go back to like if there's a crisis and when you do have to coach someone around, you need to call 911, to try to get assistance. That I did have, um, a family member, patient I was working with who, um, you know, he stopped taking medication, became increasingly disorganized and paranoid. Um, and the family couldn't get him to do anything. And so we, you know, like kind of let them know that they have to take him to the hospital. That's the only option. Um, and because they could not get him to go to hospital voluntarily, they had to um, actually call 911. And unfortunately, it was somewhat of the worst case scenario, despite trying to coach them to say it's a mental health crisis. When they called 911, the police did come and they had, almost like a SWAT team type of situation.
Mhm.
But they did not um, physically harm anyone. And the young man was taken to the hospital and hospitalized and treated and improved a lot after getting medication. And afterwards, the family was like, well, that was really scary. I don't know if I'm going to like do that again in terms of calling 911, because I felt like it was almost like over too much response. But at the same time, I saw everyone lived. My son got treated. So I mean, and of course, there's no guarantee about the next time if that has to happen. But I think, just more of the experiences you can have that are positive with the mental health system, the better. And I think it's just really the most important thing is that the patient got better after this whole ordeal.
Mhm.
But it takes a lot of coaching.
You know what? I'm just amazed at the way you do your practice. It's a very rare psychiatrist that would be doing this coaching and educating with the parents. Until we got Dr. Laitman, I never came close to anybody that gave me that kind of counsel. So I have to compliment you on
Yeah.
your hands-on approach and educating and in a specific example, getting down to exactly what they need to do. I think that's incredible. So your patients are very lucky. I hope they know that.
Thank
Yeah.
you.
Yes, and to kind of sum in a minute, I'm going to give you a minute to think about this, Dr. Graham. I'm going to ask you to kind of just share the top few tips for families and practitioners that you would like to share. But I will say, I also in the last month I spoke to the Connecticut Alliance to Benefit Law Enforcement, and they were all CIT trained officers, and I was presenting the family point of view. And my son has been hospitalized 12 times and probably should have been hospitalized 25 times, but it's very difficult to get permission to get them hospitalized, as many of us know. And we have spoken about loved ones living with us who do get violent and how safe is that for the family. And there's a lot of issues here to continue to unpack. But I spoke about the many, many times when, having been coached to say the right thing, they did not come like a SWAT team, and they came with a mental health practitioner or CIT training, crisis intervention training, and got my son gently to the hospital by persuading him, or once in handcuffs, to be fair, but without fear on his part. They were, and then the other speaker was someone who is somebody with bipolar herself, and she actually showed video of her own psychosis, and every symptom that she was showing, because her crisis team was trained, they brought her to the hospital, and she told the story of a woman one county over who exhibited the same symptoms and was brought straight to jail for 2 years. So that,
For 2 years.
well, because look, my son was in jail 10 months waiting for a bed.
Yeah.
You
Oh,
know,
man.
it's not a pretrial. You can be there. It depends on the state. I'm not going to say, but we all know that. So when you say reaching out, if families aren't lucky enough to have a practitioner like you, I'm going to recommend some of the resources we have on this podcast. Nicole Drapeau-Gillian's book about resources for families, NAMI Family to Family, which teaches you and gives you a sheet of what to do in a crisis. Families can educate themselves once they're aware. And, not everyone is as great as Dr. Graham. We know that. So families, if you feel there might be an issue, educate yourself of what to do in a crisis beforehand. And NAMI has a lot of that information right there on their website, NAMI.org. And I'm sure the Schizophrenia and Psychosis Alliance, also Action Alliance, has that information as well. So there are resources out there. Dr. Graham, do you have any particular resources that you recommend to your families?
I mean, I would say it's kind of more nuts and bolts in terms of our local area about where to go and who to
Right.
call. And then as time goes on, if there's more reading they want to do, we can give them that. But I would say in the beginning, it's really the nuts and bolts. Call this person, go here if XYZ
Local.
happens. But I will look into some resources and see to add it to the website.
All right, thank you. Any final words of the question I asked you? Like, what would you most like people to know about schizophrenia in minoritized communities? What would you most like people to understand and do?
I would say for the practitioners and the providers to be curious in terms of not making assumptions about what do you think this person and or their family believes, and trying to reflect their language that they're using to describe symptoms. And lastly, to always keep in mind like what's top of their mind in terms of priorities, because there might be something that they think is problematic and they want to address that might be different than what you're thinking is the main issue. And doesn't mean you can't work together, but it's good to keep track of that and the type of language they're using to describe certain symptoms or behaviors, because it could be different than what we might be using as clinicians. I would say for the individual and the family, particularly with something like schizophrenia, which I know you've spoken before on your podcast about the lack of insight a number of people have who have schizophrenia sometimes, especially when they're not doing as well. So it's really important that as much as you can include family members or support person in the treatment with your provider, so they can get more than one perspective about what's going on.
Hey, we love that.
And also the individual seeking treatment might be overwhelmed or confused or whatever, and maybe they're not the best person at the time to convey what's been going on. And it's good to have someone to help you out to do that.
All right. And that's good advice. No matter what your culture, no matter what your religion, if we are all families struggling with severe mental illness and someone we love, we all have that in common. So, Dr. Graham, thank you so much for joining us today. Thank you so much for tuning into this episode of Schizophrenia, Three Moms in the Trenches. You can help out the podcast and help others by sharing the podcast and by subscribing wherever you get your podcasts and or on YouTube. And remember, you can reach us at mindygreiling.com, randyk.com, or miriam-feldman.com.